Thank you very much for the opportunity to speak. So I'm just going to talk a little bit about cancer patient survival now, and talk about, again, health inequalities in cancer patient survival. Feeding really on from Jane's talk, I'm going to talk about socioeconomic class and the deprivation indices that Jane's just talked about in the context of cancer patient survival. Okay. So this is not a new research area. It's very well established. There are differences in prognosis for cancer across groups that are defined by deprivation. And this has been research that's gone back from the London School way back to 2001, 1990s. This has been really well established and really well characterized in the UK and in England particularly, because these data are incorporated directly into the cancer registry data. So we have the whole population in England, anyone who gets cancer goes into the cancer registry data, and we can link again to their postcode at their diagnosis and work out their deprivation level. And we can put that into the 5 categories, exactly the same as Jane has just shown in terms of the Welsh data. So these are very well established inequalities, but the questions that we've been starting to talk about, Ash was talking about some examples again earlier on. How should we measure these inequalities, and what should we do about them? How should we think about interventions that could remove these inequalities? These are the kind of statistical methods we need to come up with to try to kind of A, show these in a nice way, and then B, think about ways that we could reduce them. So that's what I'm going to talk about over the next 10 minutes or so. So really, we have to be careful, because then we need to think about the purpose of our analysis, because for some of certain analyses, we might want to adjust for other characteristics. And in other analyses, we might not want to adjust for differences in other covariate patterns across the groups. So we really have to think hard about the research question we're trying to answer. So the top questions here, the first two, we're just trying to quantify how big a gap there are in terms of cancer patient survival. But sometimes, and quite often in the work that's reported, we really want to isolate just the cancer element of the inequality, not just the fact that there are differences in survival across the deprivation groups, but how much is that due to the cancer mortality differences between the groups? And I'll talk about that quite a lot as we go through some of the later slides, okay? And some of our later work, some of the work that's been going on in more recent times, are again similar things that Ash was talking about, these mediation analysis, where we try to unpick what is the reason for the differences between the groups. Is it because certain deprivation groups, individuals from certain deprivation groups are diagnosed later with a later stage cancer? Is it due to other comorbidities, the impact on the treatment choices that are available? And that would link in with Jane's talk that we've just heard from. So we're just trying to think about what can we unpick the reasons, and then if we can understand it in a more clear way, then we can start to think about interventions that we could do to reduce these inequalities, which is the fourth point here, thinking about whether a screening initiative or patient awareness of symptoms, whether those are they're the initiatives that are necessary to kind of reduce these inequalities. Okay. So this is the example we're going to go through throughout the talk. And again, we're just going to focus on the least and the most deprived groups. So there are 5 groups, but we're just going to look at the 2 extremes as we go through, just to keep the slides a little bit clean. And this is the total difference. This is just a Kaplan-Meier curve, all-cause survival between the 2 groups for colon cancer in England. Okay, so we have quite a large marked difference in survival, and we can see that difference. It happens straight away from diagnosis, and it's persistent all the way up to 10 years. We see a difference in all-cause survival between the 2 groups, okay? And what we're going to do is try to unpick some of that a little bit more as we go through the talk. So we've seen there's 2 differences between the 2 Kaplan-Meiers. What could drive those differences? Well, first, there could be differences in their age profile between the 2 groups. Okay, we might want to adjust for that and account for that. And that's maybe other covariates that we might want to account for. But again, like I said, we have to be careful what we want to adjust for and what we don't want to adjust for, depending on the purpose of analysis. Okay. What also could be true is there's differences in other cause survival between the groups, right? Because we've just seen that those in the most deprived groups are more likely to accrue multimorbidity, more conditions, and therefore their other cause mortality, completely unrelated to the cancer, may drive some of that difference in the outcome in the all-cause survival. Okay, maybe we want to get rid of some of that if we're just focusing on cancer inequalities. And finally, number 3 is the actual cancer differences between the groups. That's what we want to isolate and drill down on if we're just focusing on this cancer inequalities. And that's what we're going to try to do as we go through the talk. as we've just established, basically, if you have a difference between two population groups, if that's age or country, deprivation, if you have differences in outcome for cancer, it's likely that there's going to be differences in outcome for other diseases. And therefore, we might want to control for that and try to account for that when we're trying to report our cancer inequalities, just to be clear that this is what's due to the cancer, and this is maybe what cancer services and cancer early diagnosis can kind of intervene on. It might not be feasible for us to reduce inequalities due to cardiovascular disease, for instance, from just thinking about the cancer services available in the UK. Okay. So these are a few equations, and I'm just going to flick through these very, very quickly. But this is basically the methodology that we use to kind of get rid of those other cause mortality differences between the two groups. Okay, so what we were looking at in the Kaplan-Meier was the all-cause survival, right? So this is indicated as S here, and on the hazard function, this is just the H, the overall hazard. So this is the overall mortality that's due to everything. So whether they have differences in cancer, whether they have differences in other causes, it's all rolled up into this all-cause survival differences, and that's what we were looking at before. Okay, and the idea, typically what we do in cancer is we try to get around that by separating out what's due to the cancer and what's already inherent in the population. So what we'd expect to happen between the two groups in the population anyway. So we can use population mortality life tables. So basically life tables reported by ONS to say, well, there are already differences between the deprivation groups in other cause survival other than cancer, and we can kind of incorporate that into our survival model to make sure that we're just reporting only the differences that are due to cancer when we're looking at our inequality measures. And that's the measure that we're going to try to get down to in the latter part of this slide here. Okay, so basically this H star measure, we assume that we know for an individual of a given age, a given sex, a given deprivation in a given calendar year, we know what their chances of dying due to something else, anything other than cancer. And then we can kind of say, okay, amongst our cancer patients, we'll subtract that bit, we'll take that bit off, and then we'll just isolate this lambda term. So this is just this excess mortality, the bit that's due to the cancer alone, okay? And this has some assumptions, obviously. We're relying on good data on the other cause mortality, but this is the kind of approach that we take in cancer to try to isolate the deprivation inequalities that are due to cancer, not just due to everything. Okay, and this can be called relative survival, net survival measures. These are basically trying to isolate just due to cancer mortality, how much is survival would be if you could only die due to cancer is basically the net mortality measure that we're going to see on the next slide. So as I say, this is reported quite typically, and this is from the NHS England website. Again, it's very common to report by deprivation. This is the same colon cancer example that we were looking at before, 1 year, and this is this net survival measure. So this is just taking out the fact that you can't die of other causes, just isolating the inequalities in deprivation due to cancer, and we can see the gradient that we'd expect in that the most deprived have poorer 1 year survival than the least deprived. But now we're taking away the fact that the other cause mortality is different between the groups and just saying the cancer differences are also different between these groups, and that's important, and that's what we're trying to do. Okay. As I said, and we haven't got time to go into the details now, this is obviously relies on a certain amount of assumptions. And sometimes for certain cancer sites, those assumptions may be very, very strong, particularly for like lung cancer, bladder cancer, where smoking is related. Then we might not expect the general population mortality rates to be reflective of our cancer patients that come through the door with those cancer sites because of smoking, because of higher levels of multimorbidity, and therefore this methodology, yeah, it's good for on the whole, but there are some limitations. And again, I said we haven't got time to talk about that now, but I'll happily take questions on that within the Q&A feedback. Okay. So we're going to go back to our example where we're looking at the Kaplan-Meier now. I'm going to fit a model, and it's going to use this excess mortality framework. I'm going to fit quite a few covariates. I'm going to allow age and sex, deprivation quintile to be in the model. And I'm going to fit a flexible parametric survival model. It doesn't really matter about the details. I'm just going to show some of the examples of how we can move about the different metrics and understand these deprivation inequalities in a different way. But I wanted to give the the details here on the slide. And again, I'm happy to chat after the talk about the details of the model in more detail. Okay, so we're back. This is the Kaplan-Meier that we were looking at right at the start of the talk, and we're back to this all-cause difference in survival between the two groups. But now these differences between deprivation groups, they could be due to cancer, they could be due to other causes, particularly at 10 years. Yep, there's quite likely that there's other causes of death that are impacting on the difference in survival at 10 years after a cancer diagnosis. Okay. We're going to fit that model, and I've just overlaid the model to the Kaplan-Meier, and I'll flick between the two and say the model's doing quite a decent job, at least for this Kaplan-Meier. So I'm going to take the Kaplan-Meier away now and move just to the model framework. Okay. So this is now exactly the same model and the same difference in all-cause survival between the two groups. Then we're going to move from all-cause survival to relative survival, right? So now we're taking out those are the causes of mortality. Yeah, so we're saying get rid of those. We don't want to get that H star term. We want to take that away and just focus on this lambda term, this excess mortality due to cancer, and calculate a survival measure using that. Yeah, so the gap now is reduced a little bit, and also survival is improved, right? Because we're taking out other causes of mortality as a feature, and now this gap is a true reflection of cancer inequalities in mortality, but it's a bit awkward and clunky because it's in a world where they can only die due to cancer. Okay, then we can move that forward and think about moving back to the real world and moving back to an all-cause measure. But what we're doing now for the least deprived group is taking the most deprived other cause mortality. So now we've got a fair comparison between the two lines, but we're back in an all-cause setting. Okay, so they both have the same other cause mortality, but now the only difference between the lines is in terms of the excess mortality difference between the groups. Okay, and again we can do this in different covariate profiles and look at this in, say, the over 70-year-olds. We can move around now. We're showing this. Now we've got a model, we can do any predictions that we like to look at these differences. Okay. I've got a few more slides and I won't take long on these, but basically even now we've calculated this and we fitted this model, we can do some of the life expectancy calculations that we were talking about, that Ash was talking about earlier. So we can really move on, extrapolate out all the way to a life expectancy and try to work out how much of a gap could we save, how many lives could we save by removing completely these cancer inequalities now. So if we look at the very, very bottom bar chart here, we've got the total death that we observe in the whole population, but then in the bottom bar for each cancer site, we're saying we could reduce that. This could shrink down by taking out these inequalities in cancer survival. So we can really give tangible and improvement metrics to say what could really happen for the population. And you can see for breast cancer and lung cancer, we could have significant reductions by taking out these cancer inequalities in survival. Okay, so just some discussion points, and that's it. I mean, this is a nice framework and we use it quite a lot in cancer. You could think about this in other disease areas, but it's more complicated. If you don't believe in the population mortality exchangeability that I was talking about. And there's some more really difficult questions on multimorbidity and comorbidity that are really hard to solve. And that's, again, coming up into quite a few of the talks. This is a difficult problem to deal with when we have this intersectionality, other conditions interacting with other conditions. How do we deal with that from a statistical perspective? That's tough. And I agree with the other speakers that that's something that we really, really need to think about. Okay, so just some references and that's it from me. Thanks.